Well, welcome. Thank you for the kind introduction. Um, I was when I set out to talk today, I was thinking about talking about sleep and disorders that interface with sleep and disorders of memory. I got a little sidetracked. I came across this in as early as 1925, which is way before we started measuring sleep and looking at sleep physiology in any meaningful way. Uh, there was this science fiction novel, uh, and they described this uh, hypno hypnobiosphere bioscope that you wore at night, so you could learn things at night. You could learn things at night, which I thought was kind of like was one of my dreams when I was growing up. Is if I could ever learn French by sleeping and listening to my headset, um, and but it never worked. My French is mediocre. There have been studies over the years, and people, mostly starting in the probably about 1960, really started measuring sleep physiologically the way we do now, or something that looks like what we do now. And it was about 1953 when they actually described REM sleep. So 1953 when they started REM sleep. So they're starting about 1960. The people started doing all these studies of what can be learned while somebody's asleep, and they would use various kinds of stimuli and look at different alerting parameters that we can look at on the sleep studies and the polysomnogram, and getting down to this, trying to see if it is possible to learn a list of words or whatever in your sleep, and it doesn't work very well. I did as a thing about this, particularly with the audience here, is particularly with the interest in, obviously, is dementia, memory disorders, and so forth. Uh, there was this. It's interesting to me that usually come about these things and look at these three different areas and three different, almost in an isolated way, oftentimes. And yet, from my perspective, we see these as sort of all part of the same animal. In other words, it's very common. I work with this nurse practitioner, Emily, and we almost joke about it that very commonly we'll see new patients coming to us for usually with a memory complaint or concerns about dementia. And they'll come in, they'll get their initial evaluation, history and exam and so forth like that. And then when they walk out the door, they'll usually have an appointment for an MRI scan or some blood work if it's appropriate. Um, but oftentimes they'll also have in their hand an appointment for a sleep study, um, because there are sleep issues at hand, and very often also some prescription to help to deal with their anxiety, an SSRI usually to help deal with their anxiety disorder and depression and so forth. And I always find it oftentimes difficult to tease these apart, and oftentimes people try to draw arrows in one direction or the other direction in how to approach these problems. In other words, that the sleep problems causing the mood disorder is causing the sleep problems, or what causes the memory or cognitive impairments or dementia. And I think at least some interesting, even Alzheimer have made these observations about sleep problems being a part of the whole syndrome associated with his name. Uh, and so it's long been observed that sleep can be an issue. But clinicians who deal with dementia patients, they usually know that they learn pretty early on that sleep disorders um, are, are a problem. It's not just that they're a common feature, but usually it's the sleep problem that very frequently is the major factor that drives families to institutionalize family members. Uh, that and oftentimes because of the patients themselves can deal with it, it's really the family members can't tolerate the sleep deprivation. There's also been this, long observed, there's nothing new about this, the relationships between anxiety and depression and cognitive impairment, and perhaps some overlap with that. And so I oftentimes personally find it sometimes difficult to tease these things apart. The other reason for people always show when they talk about dementia, Alzheimer's disease, they always show these kinds of graphs, and obviously the goal in life is to find out what goes on here. And indeed, sleep disorders start very early on in the course of the progression of this. And so it's, on the other hand, sleep disorders are very common. So I was going to try to delve into this, and realizing that this is not a sleep audience, I was going to go through the major features of sleep, and then as we go through, relate that to what happens with these features as people age, and what are the things that are particularly noticed, how they might relate to mood disorders, and how they may relate to dementia and neurodegenerative disorders in general. Um, we do this thing, and I think it's important when evaluating uh, various ways, various approaches. Very oftentimes you'll see lots of studies, excellent studies, that rely on self-reported observations about sleep. Obviously, it's difficult to do sleep studies on all the subjects. It'd be lovely to do sleep studies on all the patients in the whole data bank and so forth. But it's not practical for obvious reasons. But it is worthwhile knowing what it is. I mean, this is a basic polysomnogram to to appreciate some of the weaknesses and the strengths of this whole methodology, for a lot of reasons. And basically, we started measuring these things when we did this on paper. Sleep isn't sleep. We experience sleep as a continuous process through the course of the night. We don't measure it that way. We measure it in very discrete uh, epochs, 30-second epochs. It's like you sleep one page at a time. Uh, the decision about scoring these things is based upon the majority of the page. That 51% of the page is awake, then the patient was awake, and so forth. So you can see that there's some information that's lost in the whole process. Uh, the other thing is, uh, it does. There's another part to this, in that, and just from doing this, and people have observed this over the years, patients themselves are terrible at knowing really how much they sleep. They make mistakes all the time. If you ever, we do this routinely, but we'll ask patients how they thought they slept in the lab and so forth. We have really hard physiological data about their sleep, and it's not uncommon that they're way off. And they overshoot, undershoot in both directions. Um, you have to remember that even things like common disorders that we see, like sleep apnea, those folks wake up, frequently through the course of, they're very short awakenings. And you don't remember awakenings unless they're 6 minutes or so in duration. Otherwise, you just have no clue that you woke up. So um, a lot of it's sort of, it has to be taken with a grain of salt. And that happens the other way too, where people will come in and they think they don't sleep, and in fact they were sleeping. Um, so that's another common error. And we take that data, and they have these different kinds of REM sleep and non-REM sleep. Over the years, I think early on, when REM was first um, uh, discovered, I guess described, it was thought that that was the source of memory. That memories were formed and consolidated during REM sleep. And so there was REM sleep that was described, and then the non-REM sleep. And non-REM sleep here is by the end one in different three stages. This three is slow wave sleep. Also, it's also called slow wave sleep. Um, and they also have very distinct features that we see in like this N2, this middle of the road non-REM sleep. There are a couple features here. There's these spindles, these very fast activities. There are these other, what they call K complexes, um, also which play some role. It's thought maybe the spindles play a particular role, for instance, in procedural memory, for a variety of reasons. The um, and certainly have a role. And certain disorders, neurodegenerative disorders, oftentimes will have a deterioration of these spindles through the course of the disease. Similarly, this non-REM sleep, this N3, this slow wave sleep, has these high amplitude slow waves. we have definitions for these things. We define there has to be a certain amplitude and so forth to be called in three. This is now considered probably the biggest factor, although all of these are important for memory consolidation, but the slow wave sleep is thought to be play a major role. And I'll mention a couple minutes why that may be of concern. REM sleep, which is this rapid eye movement sleep, which is we associate mostly with our dreams, that's as I said early on, that was thought to be related to memory, although there was always some concern because it was first described in infants. One of the grad students, was Azarensky and Kleitman, were the first ones to describe it, and one of the grad students was babysitting and noticed these rapid eye movements, and although they were perplexed because they thought it had something to do with memory, but they figured infants aren't learning anything yet, so it was a little puzzling to them. In the early studies, would use REM deprivation, so they would show that memory was impaired when you deprive people of REM sleep. But the problem with that was that, it's very disruptive to patients, to waking them up, and so they weren't really properly controlled. So and over time, I think there's a broader conceptualization that all these stages are important. These are the features I was going to mention. And two, there are these fast activity here, these spindles or these K complexes and these high amplitude slow waves and this rapid eye movement sleep, which has these rapid eye movements and kind of very busy at EEG. So here's the sort of typical, let's digest it and put into this kind of formulation here. The blue represents the REM sleep. So you can see you go into this, you need the little guideline. Here it is. You go into different stages of non-REM sleep and REM sleep, and you go through these cycles through the night. And the slow wave sleep tends to be skewed at the beginning, and REM sleep tends to build up through the course of the night. And I'll get back to it, but it's you could see how it's the whole interplay here that's important. This, if you layer this out, if you notice this, there's we have the different layers, stage one, which is the N1, N2, and 3 REM sleep over the course of a lifespan. This goes up to 55. It kind of flattens out a little bit after this. You can see that young children need a lot more sleep, sort of levels out, and maybe some decrease over time. It's generally the part here, it's the slow sleep that tends to really, as a percentage of total sleep, really diminishes with age. The one that I said was so important for consolidation of memory. REM sleep is thought to be much more involved with the emotional memories. In fact, REM sleep in general has a lot more emotional valence attached to it than non-REM sleep. When people describe things like dream enacting behaviors, they tend to be somewhat violent and aggressive in nature, or negative emotional valence. The other feature about this that will tie this all together, it's here, is appreciative of the circadian rhythm, and and this is just a cartoon of the whole system here, but the circadian rhythm is that thing that governs our 24-hour clock, that governs that we sleep at night, we're awake during the day in general, and there's some regularity to our sleep pattern. One of the key components here is it's very light sensitive, and the retina is particularly implicated in this, in particular certain cells in the retina, melanopsin cells, which then feed to the suprachiasmatic nucleus. And then that, through a somewhat circuitous pathway, feeds onto the pineal gland, which generates melatonin and feeds back on the suprachiasmatic nucleus. And it helps generate these kinds of curves. The sleep-wake cycle is tightly linked to our core body temperature, which is represented here. And sleep-wake is a 24-hour rhythm. So it brings up a couple issues. Number one, uh, uh, that suprachiasmatic nucleus is very vulnerable in a lot of neurodegenerative diseases. It's been shown that the impact of amyloid and tau and probably even synuclein proteins are associated with cell loss in that suprachiasmatic nucleus. So the circadian rhythms are particularly vulnerable to the impact of neurodegenerative disorders. Um, Number one. Number two, and normally with aging, there's this whole magnitude, the strength of the circadian influence decreases with normal aging, let alone with the loss of additional cell loss. Uh, so the somewhat is generally thought of as the amplitude of the magnitude of the impact is we can which is in part attributed to the fact that in normal aging there's greater fragmentation of sleep at night in general. Uh, what are some of the other features? There's an interesting other shifting of this clock here. One of the things about this circadian rhythm is it does correlate with levels of function. So that, and this represents as the core body temperature increases through the course of the day. And there are certain points here, like during the day, when it's sort of considered to be peak function. And at these low points are low function. So if you do very sensitive testing, people don't function as well at these points as they do during here. So even well-rested shift workers overall tend not to do as well as day workers. And this has been shown over and over again. Um, you would think that with this greater sensitivity and the fact that with normal aging, this curve tends to shift to our left. That is, there's a normal drift towards showing that patients will go to bed earlier and wake up earlier normally, which is the usual explanation. If you go to nursing homes in South Florida, you'll see the patients tend to wake up early in the morning, and it's for a combination perhaps of biological and social reasoning that drive that shift. Well, dementia patients are particularly vulnerable to these shifts in the sense that if you start out with some cognitive impairments, they'll be amplified. And in general, patients with cognitive impairments don't do as well here as they do here, and it can be more obvious oftentimes. So there's greater levels of confusion and sometimes these sundowning behaviors. But even in the more subtle levels, you would think that should be a lot of concern to really controlling for time of day of if you're going to do sensitive neuropsychological testing, time of day can be for some patients more than others. And even for most patients, there's some subtle differences, but some patients it's much more dramatic. Time of day can be very critical. And, oftentimes, in real life, we don't have the luxury of controlling for time of day between evaluations of patients. Uh, I don't know. Maybe I should ask. I don't know. Like in the HOPE study, if patients are always given testing at the same time of day, uh, each time they're monitored, or if it just is according to the schedule. Uh, there's a See if I got this right. And there are a variety of factors that can impact that circadian rhythm um, as well. Some of it has to do with changes related to normal aging. Some of it has to do with the loss of retinal cells and particularly those melanopsin cells. Um, some of it has to do with the vulnerability, as I mentioned before, the suprachiasmatic nucleus. Some of it has to do with the fact even with normal aging and cataract formation, there's a yellowing of light and uh, and what that leads to oftentimes, and it's the blue light actually that is really drives the circadian system. So there are a lot of factors which in turn can affect the circadian system and sleep. Um, and finally, there's just a little cartoon of the lymphatic system, the system that helps with the clearance and and is thought perhaps, I guess, to be related to the so-called clearance of all those toxic beta amyloid fragments and so forth during, and which occurs maximally during sleep. If you have a system, for instance, that with this disruption of sleep, one might predict greater production of beta amyloid and decreased clearance, which in theory, at least, one would expect could be somewhat toxic. Um, so this interface is which should not be surprising. And finally, I throw this up. These are the major centers, nuclei scattered throughout the basal forebrain and brainstem that are implicated in sleep modulation. And you can, it's pretty obvious looking at these to see that there's an overlap between all these centers that are implicated in sleep and the ones that are implicated in a lot of our neurodegenerative disorders and in mood disorders. You know, there's the locus coeruleus and with norepinephrine involvement, the raphe nuclei and serotonin, the dopaminergic nuclei as well. There are the histaminic nuclei in the tuberomammillary mammillary nucleus. In the pons, there are these two clusters of nuclei that are involved in supporting REM sleep, and they're largely cholinergic. So there's a big, and cholinergic systems are important. Obviously, with Alzheimer's disease, there's a loss. Well, obviously not the only issue, but one of the things that was always implicated in Alzheimer's disease was the vulnerability of cholinergic neurons, mostly in the basal forebrain. But as those cells are lost, in parallel, the cholinergic cells in the brainstem were also lost. And so there are changes in sleep that parallel the changes in Alzheimer's. And so it's not a matter of one necessarily driving the other, it's perhaps one being a mirror of the other. The one other one I mentioned here is which is of all these is probably the most recently described is the orexin system, which is in the hypothalamus. Orexin was brought attention to early on because that's the particular neuropeptide that's deficient in narcolepsy. And there's a loss of those orexin cells. And in orexin, and I think it's still being clarified, but orexin is also implicated in amyloid and tau clearance and synthesis. And so I think the relationship between these sleep systems and as well as in other changes in neurodegenerative disorders, I think again is more reflective of these things are sort of markers of one another rather than necessarily causing one or the other. We'll come back to that also as well. And one final thing, which I think relates to this interplay between these factors here. If I haven't made the point, I showed this before, this hypnogram, the different stages of sleep through the course of the night. And, you know, just to show how these things are related, notice how the REM sleep here increases in duration, slow sleep tends to be mostly here, and the REM sleep increases in duration and the slow sleep tends to disappear. We have this, where there's a shift in the REM sleep pushed more to the beginning, this REM pressure, there's an increase in REM sleep. And if anything, there's some more suppression of slow sleep, which is now pushed towards the end of sleep. Sort of features that come up with depression. And so I show this here. These are just depression is associated with sleep variables. And I'll come back to this again. Depression, in addition to leading oftentimes an increase in REM sleep or an increased REM pressure, can be a decrease in non-REM sleep, which I said was also implicated in memory, uh, particularly in memory consolidation. There also can develop an increase in sleep need. So this depression can be associated with the actual need for sleep and hypersomnia. Similarly, we call it a first night effect, but we see a lot of anxiety related patients. They have a sort of a different factor. They may have actually, and this you see this in the first night effect, um, where you see suppression of REM sleep. So this first night effect, as well as other fragmentation of sleep, difficulties adjusting and so forth, the things that people would think of commonly, but also there's a suppression of REM sleep. And if you do sleep studies, which rely on a first night in the lab, a single night in the lab, and you don't try to account for this, you can be misled sometimes, right? Because you don't account for this. Um, again, it's hard to account for it. And I bring these things up all as a way of explaining, number one, there's an obvious relationship between those three pieces, sleep, memory, cognition, and um, mood and anxiety, um, and which just makes it complicated, and it makes it complicated even to measure these things. Uh, what about we've sort of gone through some of these things. I sort of um, want to hit upon a couple. Let me see if I do this right. Let's first actually briefly talk about some of the changes that have been observed in Alzheimer's disease, which can contribute to some of the disruptions in sleep and some of the measurements. And I have here, you can see, there's some changes in the sleep architecture itself that are always described. As I said before, there's a decrease in REM sleep. The decrease in REM sleep is thought to be powerful enough that people oftentimes have suggested that it be used as a biomarker for measuring the progression of Alzheimer's disease, um, as well as these changes to some extent in non-REM sleep. Um, the and here is just to illustrate that the two major cholinergic centers, one is in the basal forebrain, but the other's in the pons, and one's related to REM sleep, one's related to is thought to be part related to Alzheimer's disease, and so it's not uncommon that you'd expect to see um, those things change. And these are just some other things showing that early in the stage of Alzheimer's disease, you can see some changes in sleep efficiency and durations of sleep. I'll get back to that actually a little later. The other thing is, as I mentioned before, is these are those spindles that also tend to diminish and be affected during REM sleep, during Alzheimer's sleep. They tend to have trouble changes with frequency and amplitude and duration that are particularly vulnerable to the progression. So I was going to talk a little bit about um, the interface between uh, these sleep changes or different things that people have looked at in sleep and neurodegenerative disorders. Uh, one of them is to look at things like sleep duration. And most of these studies that I'll show you, oftentimes they rely on self-reported sleep duration, which has its limits, uh, but oftentimes is the best marker available. And something that I'll show you, popularized by the National Sleep Foundation several years ago when they would do these surveys, these very large surveys. And I'll get to those in a minute. But again, there are a lot of factors which affect sleep duration. As I said before, there are age-related changes in sleep duration. Mood can certainly have it. We know that anxiety patients oftentimes may sleep less. Depressed patients may sleep more. And these are not perceptions, these are actual things that we can measure in the lab oftentimes, sometimes we'll see depressed patients who become so sleepy they mimic narcolepsy. Uh, uh, and then there's this whole interface between uh, the impact of these changes in sleep stages, and its impact on the lymphatic system. But let's look at some of these different things that have been looked at. We'll look at sleep duration. Um, these are all the things I've listed here are things that can impact sleep duration um, on a day, which includes everything from, time of the year, seasonal factors, mood changes, and so forth. Um, there have been a lot of studies over the years, and they vary a little bit on patient population, ages, what they call, and oftentimes they'll try to divide patients into short sleepers and long sleepers, and those boundaries may vary a little bit from study to study as to what is a short sleeper. The average sleep, what's the normal sleep for adults? The task force several years ago with American Academy of Sleep Medicine to address that, and they're supposed to be evidence-based. There was no evidence, so they came up with a consensus, and so the consensus was 7 hours is the number. Um, so oftentimes most studies will use as the long sleepers being 9 hours, 10 hours, in terms of some of the sleep disorders that we see. Sometimes the cutoff is 11 hours, and the short side would be 6 hours. It doesn't mean that people who are long sleepers, short sleepers, necessarily pathological, because there is a normal bell-shaped curve. But most of these studies come up with some variation of a U-shaped curve, where the very short sleepers and the very long sleepers are the ones who have the greater uh, morbidity, comorbid disorders, and also some measures, as I say, these quality of life things that are done by the uh, National Sleep Foundation, and these looking at risk for dementia. Um, there was actually this pretty recent, just this year, um, published a very nice study from the Framingham uh, that looking at um, these long duration, looking at 2 points of time and looking at the increase in duration over time, but then doing of amyloid amyloid burden, tau burden, and presumed vascular burden. And here at least indicated that the long, if I read this right, that the long duration seems to be better correlated with the vascular burden than it is with the amyloid or the tau burden. There's a lot of statistical modeling which uh, I found very interesting, but it's a very interesting finding. One of it that raises questions, the obvious question in somebody's mind is, in clinically, if you were to ask me what's one of the common things that we see that would lead to long duration of sleep in patients, one of which uh, is depression. I mentioned that before, but and other medical things, but also something like sleep-related breathing disorders, obstructive sleep apnea, which in turn is very highly correlated with all sorts of um, cardiovascular, cerebrovascular comorbidities. And so the fact that there might be a correlation between vascular burden and and long duration of sleep is quite a reasonable speculation that would be found. It was fascinating study, a fascinating paper. What about some of the other things that we could look at in here? That's just looking at duration. Insomnia. Now, one of the things as we talk about insomnia is that insomniacs don't sleep a lot. They don't sleep, and they don't sleep in general. They don't sleep during the day either. They're not sleepy people. Uh, and yet the sleep disruption is associated with increased levels of increased risk of neurodegenerative disorder, particularly when was looked at Alzheimer's disease. Let's see, and it's unclear, is this increase in risk, is it due to again this disruption of these cycles that increase wakefulness, may be associated with increased amyloid production? Is decreased sleep related to decreased clearance? Is it additional inflammatory markers that are a culprit here? Um, what about obstructive sleep apnea, which I alluded to before? Um, and basically, what it's due to is people are at night, go to bed, and there's relaxation of the muscles, and without getting into the details, it's just a closure of the airway and obstruction. So people will have intermittent stop breathing through the course of the night. And so it leads to a very inefficient sleep. There are two factors that happen from that. One is the intermittent hypoxia associated with intermittent drops in oxygen levels, which in turn is bound to have its own toxic effects, particularly on the cerebrovascular system, and and uh, and the fact that there's sleep disruption, which we've already talked about. Um, there have been some studies suggest perhaps the better correlation with later development of cognitive impairment and dementia might be the intermittent hypoxemia. Uh, and there is a clear-cut relationship, as I mentioned before, between sleep apnea and all sorts of other elements involved in cerebrovascular disease. Um, and so it's something which certainly deserves a lot of attention. And certainly there are late cognitive impairments associated with certainly untreated sleep apnea, um, and risk for dementia. Uh, Short-term sleep disruption may lead to executive system dysfunction, which is slightly different. What hasn't been shown convincingly is treating sleep apnea prevent these complications? And there's something like, which is which has been one of these things that in the field, people believe that treatment will prevent these complications, but it hasn't been convincingly demonstrated to at least CMS, the people who pay for the treatments. Uh, and finally, um, I was going to talk a little bit about, there's this disorder that we refer to as restless leg syndrome, which at the face of it, it's let's see, got there. At the face of it, these are the basic elements of it. It basically is this problem, this restless feel, this urge to move that people have usually in their lower extremities in their legs, and um, this urge to move. Um, and it's usually worse at night, and it's worse when people go to relax. So you can see, and it feels better if you get up and move around. So you can see how it would interfere with sleep. In some ways, it's a disorder of wakefulness, uh, but with those other features. And and it can lead to problems with falling asleep for some patients. Uh, and it's interesting, usually in life, it's been associated with iron problems with iron deficiency, um, chronic renal failure, and it's also been popped up in pregnancy. But and those have always been the strongest correlations, even back when this fellow first described it. Uh, um, Ekbom first described this like in the mid 40s, and it's interesting in that um, even though those are the things that pops up, it pops up here. If you look at large epidemiological studies that sort of map this, and it's not that hard to map restless leg syndrome because there's a single question that's been validated to be relatively sensitive uh, for this. And in fact, we use it in the clinical setting all the time. But uh, and when you do that, there are these correlations with all sorts of other problems that emerge and that only sort of come up in these large epidemiological studies, and where there is some correlation with diabetes, obesity, and so forth, and in turn, all these other all these factors are involved in vascular disease. Um, so what is the interface then between this restless leg syndrome, since it's associated with all these risk factors? What is the correlation? That's not directly addressed. Uh, and I threw this in. It's not the one thing that comes up. I think that in many ways, some of these things that we've talked about should be addressed early on. I've oftentimes said that particularly elderly patients, but even middle-aged patients coming to the sleep clinic, one should consider cognitive, especially the older patients. Um, and just like the patients coming with memory disorders, one should consider their sleep problems. Uh, the one that's always kind of weird said was this REM sleep behavior disorder, which is much more specific. Um, and that's that dream enacting behavior that I alluded to before, um, which is predominantly associated with the synucleinopathies, the REM sleep behavior disorder, um, uh, Parkinson's disease, uh, and the other synucleinopathies, multisystem atrophy, and so forth. And uh, although on occasion it might be associated with other neurodegenerative disorders, the general feeling is if you see an idiopathic presentation of this, that they're certainly going to be developed. I think they're certainly going to develop one of these. So usually the conversion is about 8-9% per year. Um, that you'll see the development, because this can frequently precede the development of the other symptomatology of the cognitive impairments or even the motor impairments. Uh, and so it's oftentimes considered by those folks as a biomarker, at least for that particular disorder. Although I know that I guess in your CTE patient population, there's some increase um, uh, in this REM behavior disorder. Uh, but there's also some changes of synucleinopathy that have been observed. So I find that sort of a relatively unexplored area of intrigue about that particular correlation. Um, the thing about identifying these sleep disorders in the context of these memory problems is that oftentimes these sleep disorders, what's his name? These sleep disorders are more treatable. And so the final point here is we have this interplay between all these different variables, these sleep disrupting factors, uh, the increased risk for developing cognitive impairments and dementia with aging, and there's this interplay with mood disorders, and you have this sort of three clusters of findings. And my approach to these on a clinical side, which is different than looking at these and trying to establish causality, uh, is to treat the treatable pieces. Um, but I think there is this definite correlation. Um, and since we're not going to have any hypnobioscope to help me out, I think, well, we may stop there. I think I may be a little bit earlier than I had anticipated, but um, maybe see if there are any questions.
Thank you, Dr. Auerbach. I would like to open it up to anyone if there is any questions.